Here you go. Here we have got Dr. Daniel Karr, Professor of Pediatric Ophthalmology and Strabismus in Ilk Eye Pediatric Eye Clinic in CEI Institute, OHSU in Portland, and I'm very lucky to have a mentor or as a Dr. Daniel Karr for my fellowship in CEI Institute. Here I got a small talk with Dr. Karr. Dr. Karr, would you please uh, tell us something about how you manage pediatric eye cataract at in CEI Institute?
I should say I'm very happy that Dr. Mall is here with us also. So it'll be a nice rest of his fellowship. So pediatric cataract, should I start with younger patients and just?
Yes, sir.
Okay, so the very young patients are maybe easier and harder to take care of. First of all, I don't put intraocular lenses in patients younger than a year of age, and so the very young patient, we operate on them when they're more than 1 month post their full-term birth. And so if we have a premature baby, we wait until they get to their full-term birth date, and then we go 1 month beyond that. And the reason for that is because we think we have a decreased chance of having postoperative glaucoma. If we then operate, if it's a unilateral or bilateral, the surgery is done, and then postoperative care will be involving contact lenses almost exclusively. Sometimes it will be aphakic lenses depending on the patient and compliance. During the surgery, we typically use an extracapsular cataract approach, and we use a phaco machine, but basically we could use it as a bimanual approach as well, just for the way we use the approach. And postoperatively, they get subconjunctival antibiotic and steroid injection. Then they're followed with an eye shield that continues for the first month after the surgery. They are seen the first postoperative day, and sometimes they're seen the same postoperative day if they're going to be leaving and traveling far away. We see them that night. But most of the time I see the patients the next morning. If everything is fine in terms of intraocular pressure and wound, the wound is sealed well, the chamber is formed, and there's no sign of any concern for leak or potential infection, then they're seen approximately 1 week later. And they stay on a 1 week follow-up for the first month and sometimes 2 months, depending on what their progress would be. Each visit entails checking intraocular pressure, and as I said, they continue with an eye shield for the first month. In older patients, we will have the shield on at nighttime. If they wear glasses, they can have glasses during the daytime. And but then it's the same type of follow-up. We see them the first day, we see them again the first week after that, and am I still on?
Yes, sir.
And we check their pressure, check their vision, and go to intraocular lenses at approximately 1 year of age, and then it's basically very similar follow-up. In terms of one thing we didn't talk about was the workup of the patient preoperatively. For the young patient, if they have no family history of cataract, we do more of a workup. We do the torch titers, metabolic screening, and depending on what the patient looks like, they may have chromosomes done as well to rule out some type of syndrome or chromosomal error. The older patients will have a selected workup depending on, again, family history and their age. The patients who have a positive family history usually will still have at least the torch titers and looking for reducing substances and galactosemia to make certain that we don't take a cataract out that doesn't need to be taken out. But I think otherwise they're reasonably similar. We start amblyopia therapy as soon as the refractive error has been corrected. And so for the early cataracts, that's typically about a month after the surgery. we're now putting the contact lens in at the time of surgery in certain patients, so we can actually start amblyopia therapy earlier.
So, in your practice, how you calculate intraocular lens in pediatric cataract surgery?
For those who are going to have the intraocular lens placement, we're fortunate that we have the photography team, which is actually also, they do the ultrasounds, they do the A scan, B scan calculations, and also the intraocular lens calculations. So for the young patient, they come to the operating room where we typically do an examination under anesthesia to make certain we know exactly what's happening with the eye before surgery. We do IOL calculations then because we can do the axial length, the keratometry, all the biometry. We can do B-scan if we can't see into the back of the eye. And then we perform the IOL calculation. And as I was telling Dr. Mala before, I don't know specifically which calculations we were always doing because they're basically plugged into the computer. If it's the holiday or the latest version of the holiday, but we tend to use 2 different calculations on each of the patients, and then I review those and typically look at what is close to emmetropia for the patient. And I consciously do that knowing that they're going to be overcorrected later on because I feel it's more important to have them corrected now. And if I do the same thing with a contact lens. If we have a younger patient, we overcorrect them about 3 diopters to give them a near point of focus while they're developing vision. With the IOL patients, I ideally would think about overcorrecting the younger ones several diopters, but the reality of it is that I don't. I correct them for distance because I feel I can get glasses on them for the near correction. But that's pretty much what I think most of us do here. We do not say that they're going to be 5 diopters less hyperopic in the future, and therefore we're going to undercorrect them with your intraocular lens and then give them glasses with a bifocal because we still have compliance problems with patients, and if we cannot get glasses on the patient, at least they'll have one point in space where they're actually focused and hopefully make some amblyopia recovery.
So your main message is to our philosophy of IOL calculation in pediatric cataract surgery is correct now and then keep on correcting in future.
That's a good summary.
Thank you. Thank you very much, Dr. Karr, giving us your valuable time for pediatric cataract management.
My pleasure.
Thank you.
Thank you.